record, Yvonne?
I am, yes.
We're not live streaming today because we haven't got the technical capacity to do so, but we are recording and then it will be uploaded at the end of the meeting later on today, I think. Well, we'll move on then. Welcome, everybody. We've got apologies from Asiya Yunus and Ahmed Galantia and Julius Parker. I don't think we've had apologies from anybody else. Anybody know of anybody else? No. Declarations of interest. The register of members is available in the papers. Are there any other interests not on the register that we need to declare, given the agenda today? No. Good. Right. Thank you very much. Minutes of the previous meeting. Any points of accuracy that anybody wants to raise? No. Good. I'm whizzing through this agenda. Apologies. Then we've got the Chair's report. That just really highlights the summary of previous meetings that was presented to the governing body. Bruno, you wanted to pick up a point with me. You're on mute at the moment.
Sorry about that. Yeah, I was just wondering if in your report you might be able to say a word or two about the kind of transitional arrangements that there might be between now and July in your later on.
So from my perspective, we've got one more meeting in June of this committee, and during the intervening period, there's some work going on to map the different functions to the new structure, but I don't think the new structure is completely confirmed yet. But Andy, did you want to add anything?
Thank you, Susan. I think that's a fair summary. So yeah, one more meeting June the 15th of this, and hopefully we'll be presenting sort of a handover document about what happens from July the 1st, Bruno. We don't have any NHS England guidance around executing delegated functions from July, but I think it's safe to assume we pretty much will have what we have now, but in a different format. So I'm fully expecting that the local primary care management groups will continue in a very similar course to how they do now. And I think there was still a requirement for a South West London primary care contracting group. But as I say, we are trying to work through various scenarios at the minute. So looking at, for example, what goes to our agenda now, what might happen from July onwards. But the delegated commissioning arrangements that we have through NHS England will, I believe, continue. So it's fair to assume that there will be a function to support that as well.
Okay, thank you for those clarifications, Sue and Andrew.
Thank you. Just actually for an amendment, Julius isn't apologising for the whole meeting, he's just going to be late. So we'll see him at 10:30. Welcome to those who've just joined. Nice to see everybody. We're on the item on the finance update. Have we got Neil on the call? Did you want to highlight the key messages for us and some of the risks that we're facing or not?
Yeah, thanks, Susan. Good morning, all. So yeah, hopefully you've all got the report in front of you. I'll take it as read and I'll just pull out sort of the key messages. So on slide 3, I think page 21 of the pack, just to note that the additional allocations in the 4th bullet point down. So we've had the 847k for the long COVID devs, the impact and investment fund has come through, leadership management, winter access fund and the additional roles reimbursement schemes. To note that the overall position is still showing the overspend, which forecast out turn around 2.2 million. That's not changed throughout the year, so that's still holding, but obviously still needs addressing. I think a couple of other points around the additional roles reimbursement scheme. So we did have a forecast for a much higher uptake of that scheme. That has now been revised in the last couple of months. So we're not now going to be claiming the full amount, but just to note how the money flows through with that, there's an amount of money in the baseline which we've exceeded, and then any reimbursement above that just comes through to the CCG each month. So it's not like we're giving any money back, it just means that we're not going to claim as much money from the scheme. And then similarly with the Winter Access Fund, we'd originally set out to spend 6.5 million. Currently that's looking around about 5.5 million that's come through. So that's the sort of general overall position. On slide 5, which is 23 of the pack, the primary care transformation money. So this is the additional funding that comes through ring fence for transformation. And we are anticipating that all of this will be spent by the end of the year. I think there is still, or there was an underspend against that. So we are looking and working hard with the teams to ensure that that gets fully committed by the end of the year. And then on slide 6, the premises principles, this is just a flag to the committee that we've recognised that premises largely has been neglected over the last few years, and due to capacities within the team, we've never really had a chance to do a full root and branch review of all of the premises costs that are coming through. So what this slide has done is hopefully set out to you the process that we're following. We've put some additional resource into the team to carry this out. But we recognise, given the lack of work on this area, it's going to take at least 18 months probably for this to start to work its way through. So I think that's a positive move in terms of the team taking this on, but a lot of hard work ahead of us. So that's just basically for the committee to know what's in the report, but happy to pick up any questions anybody may have.
Nicola.
Thanks, Neil. So sort of 2 linked things really. One, the ARRS funding, which although we haven't claimed as much from that budget as we could have done, meaning practices have not recruited to the posts up to the maximum they could have done. It's still a massive, phenomenal effort that people, this is extraordinary what's happened. And I think we're one of the best performing in terms of utilisation of the ARS fund. Is that right, Andy? Are you going to nod at me there? Yeah, so it's absolutely amazing. You know, to be recruiting new staff in the current environment in new roles, which means real changes to how practices are working operationally, how PCNs are working, is phenomenal. But what I'd like to do is link that to the question of premises, although I'm not sure whether premises is the right word. I think more estate, really, because I think what you're talking more about is the nuts and bolts of how we manage premises issues in general practice. But there's something bigger than that, which is recruiting all these ARS roles. Practices are really struggling to find space, both from a literal desk point of view, but also the infrastructure that goes with a new person coming into the practice, the IT and everything that goes with that desk space. And sometimes it's not just desk, it's consulting room, depending on what the member of staff does. And so a really big kind of overhaul of how we manage primary care estate is needed from that point of view, in that we've got all these new people who can do new things and it's brilliant, but they've got nowhere to be. And that's really kind of, I think, going to have an impact on the next year's worth of recruitment, because the budget expands again this year, doesn't it? Was there a question in there? I'm asking myself. No, I'm just saying it.
An observation, but one I would say I definitely recognise in terms of the expansion or potential expansion of the estate. But we have Borough Estates Group meetings where I would expect that these sorts of issues should get talked about, because there are opportunities with things like void space or doing things differently, presumably within primary care. So all of that discussion probably needs to happen, one at a Borough Estates level, but then equally would find its way through into the South West London estates strategy as well.
Thank you. And I would just suggest that this group, in whatever form it takes in the next year, that, at a strategic level across South West London primary care, that we remain absolutely sighted on this and working on solutions.
I mean, that's really helpful, Nicola, because I was going to just sort of follow on from that. So the table that you've put in the premises principles, that's more about sort of managing financial risk and premises risk in terms of general practice. A slightly different, more sort of operational issue to the one that Nicola was talking about. Would that be something that the finance forums that will be developed will be cited on, or is that something that primary care will continue to be focused on?
So I think it's through the borough estates groups. I think that's where the discussion needs to happen. It's not a finance exercise. Clearly, there's a financial impact and a financial risk associated with it. But I think some of the solutions are about looking at our estate overall and saying, well, where are those opportunities for us to be able to manage this within? And equally, it feeds into.
So I meant your paper, not Nicola's point.
Well, so you're right. This is about the operational issues around premises. It's not the strategic that Nicola's talking about. That is a separate discussion. So if that was your question.
Yeah, sorry, is that the stuff that you put in your paper, is that going to be monitored by, I mean, obviously led by boroughs because they're the ones who have the insights into the practices, but the oversight in terms of the financial risk that generates, that'll go through to the finance forums that exist with it.
Well, yes, but again, it's a multidisciplinary team that's been set up. So I know working with Katie's team, the finance team within what Katie looks after, that will be the whole approach to it.
Right, thank you, Andrew.
Yeah, I think there's just in brief two points really. One is there's certainly something as the slide references about an improvement plan, which I think really is around internal improvement. So making sure that the various processes between primary care, finance are connected, and we're on top of all of the historical issues that we've got. And there's a whole long list of those, well, that we are working through and now have a plan for, as this slide suggests. And then I think the second one, which I'm sure Mark will talk about, is really around it's less about the estates as an enabler for the overarching primary care strategy and work that each place wants to deliver, really. So it's the role of estate in that, and that will clearly be something really important for the local place committees and its governance structure to try and really get to grips of as well. And increasingly, as Nicola said, we're trying to look at this at a PCN level. So, you know, there isn't necessarily the capital or the resource to go around for every single practice, but it is about how do we try and work across at PCN level and help them make the most of their clinical capacity and resource as well.
Okay, thank you. Mark, did you want to add to that?
Well, I think Andrew probably covered it, but I do think a couple of things. I think just going back to Nicola's point, yes, we do benchmark really well compared to our London colleagues around the use of the additional posts. That's fantastic. I think the premises principles, but also the grip that we're now beginning to get on knowing what our estates issues are, I think that's really welcome. It does come with risk. Because you don't know what you don't know until you've until you've gripped it. But it is a necessary, we need to do that so that we can then build the strategy going forward as well. I think there's one other thing, but that's not about estates that I just wanted to touch upon with Neil in terms of the finance. The overspend, and that's a kind of historical overspend, and there's been lots of conversations at the finance committee about what we might do about that. So I wondered whether you just wanted to give us a line basically about what the plan might be going forward to look at that, to address that kind of historical overspend.
Yeah, so I think it would be fair to say that we are making very slow progress in understanding what the historical position around that is, and it's very difficult to break this down by borough or basically put back in place what we had before the CCG came together. However, that's what we're attempting to do, and then hopefully what we can start to look at is where exactly the issues are, and more importantly how we might be able to address it, because I think the point that Nicola raises, I can only see more financial risk coming our way. We know there are lots of proposals for new premises developments that are going to cost us probably more money than we're currently paying at the moment. So I think that what we've got to do is we've got to surface all of that, get that all out there, then we can all be clear about what the issues are. But this is not an easy budget to actually address that underspend, because largely the budgets are non-discretionary, so we are really limited as to what we can actually do. But we are working on, and I'm hoping that what we shall have for the new year is some of that set out, so we know exactly where the issues lie within the budget.
Yeah, and I just want, you know, I think it's good to acknowledge the complexity of it. I just think for the Primary Care Commission Committee, just to know that we are doing something about it. Yeah, I just wanted to. Yeah. Thanks, Neil.
Nicola, did you have your hand up just now?
I was just going to make so if Julius were here, Julius would point out that this is such an important budget because although it's only, you know, less than 10% of our total CCG budget, it deals with 90% of patient activity. I'm sure he would say that if he was here.
Yes, I'm sure he would. David, did you want to add any comments on the finance update?
I mean, I guess the only issue is if you look at the detail, particularly around some of the premises, you've got a series of legacy issues as well as new issues. So it's, and Neil knows this, but it's dealing with both of that. So whatever's done has got to address both, because at the same time as we're trying to deal with some of the legacy issues from years ago, you've got new costs coming through because there are new developments all the time. So the new structures are just going to have to pick that up. So that's got to be something in when we do the handover, we need to pick that point up.
Okay, thank you. Right, thank you very much, Neil. Anybody else got any questions for Neil? No, very helpful overview, thank you. Right, so we move on then to the next item around the contracting intentions. Do you want to kick off with this, Andy?
No, Kate is going to kick off with it for 5A and 5B.
Yeah, so thanks, Andy. So yeah, Susan, I'll do 5A and 5B, and then Paul's going to do C and Emily D. So we'll just do a bit of a team effort, but I'll do the first two items.
Lovely,
so the locally commissioned service, obviously, the detail is in the pack. The LCS, obviously, a range of services commissioned at borough level and renewed and rolled over annually. There's a paper from each borough attached as appendices to the cover sheet, so you can see the long list of suite of services available within each borough. They cover various clinical services, things like diabetes, wound care, respiratory. There's a whole raft of things that you can see in the paperwork. The paper is here just to request approval for the renewal and rollover of the services, taking us through a further year to March 2023. To note that obviously there have been some challenges with review of the services due to COVID and the kind of competing priorities over the last couple of years. There is a comprehensive review underway for LCS. Obviously, there's a huge, across LCS and Premium, we have about 160 specifications for South West London, so it's a huge job. But we have identified a few services in LCS that are already under review. So the first one that's been picked up is the Smi Health Checks, which has been under review since September, and there's a huge amount of progress that's been made with regard to trying to kind of standardise across South West London, look at opportunities and looking at ways of removing duplication with other funding streams. So there is a lot of progress being made with regard to review, but just to note, it's obviously a complex exercise, and the services are of kind of varying levels of complexity. So we'd chosen SMI and prostate to make a start on, and would intend to continue reviewing incrementally through next year as much as we can. So it's just to note that work is underway, but with the request to roll forward the raft of specifications for a further year while that review continues. For SMI, prostate or others that we're able to review, there would be notice to practices in due course of changes, etc., that may come in later in 22-23 or beyond. So at the moment it's rolling forward as they are, with sort of due notice to be given as and when required, as the new services are defined. So I'll stop there, happy to take any questions before I do the premium item.
So can I just pick up then, Katie? We've obviously had a series of these conversations at the end of each year to roll over the LCSs. Yeah. You've now got a plan, but I think in terms of thinking through the handover to the next organisation, just need to be clear that this will need to continue for some time for certain specifications, because it's going to take you a time to get through them all. So where we've set perhaps unrealistic expectations in the past that all this will be completed and that we wouldn't be rolling over year on year. I think we just need to acknowledge that we will be, but there is a plan for tackling some of those specifications over the next 5 years or whatever the time frame would be to get through all of those. And it's important to get them right, isn't it, for the service, than to try and do things too quickly and not get the right solutions and model of it. So I've got that understanding right?
Yeah, I think exactly. Yeah, I think that it's hugely complex. So yes, it would be quite appropriate, I think, to say that we wouldn't be able to review all of them next year, even if COVID hadn't happened and we didn't have. I think I suppose with the SMI one, I think there's a huge amount of progress and it's in a really good position, but it's taken a few months to get to the point, obviously, of understanding. You've got clinical views from all of the 6 boroughs, trying to look at what's been kind of commissioned and funded differently in the past in different boroughs. It may not be appropriate to standardise all of them, but we've sort of thought where it may be appropriate, in the best interest of patients, we can look at that. But obviously it's a huge engagement piece across a number of parties and sort of partners. So yes, I think that was a fair reflection. Yeah,
but there is a plan, and it is clear which ones are going to have. I mean, are you prioritising based on ease or complexity or importance, or how do you decide?
Yeah, there was an initial desktop review that was done of all of the services, and they were sort of categorised into levels of complexity and with sort of different criteria about how we might prioritise them. But yes, some of it is about sort of the complexity of the service, how it relates to other things in QoF or the PCN DES, for example, where there may be opportunities as well. So yes, we have a sort of comprehensive desktop review that was initially done before we started on the SMI, and there's a programme board that had determined where we thought the best opportunities were based on what we could achieve, sort of the level of difficulty versus the opportunity, etc.
Okay, great, thank you. Mark, did you want to come in?
So I'm not challenging the rollover or anything like that. So and acknowledge the complexity. As mine's a governance-y question actually, because LCS funding will be in the new world. I'm assuming it will be kind of borough-based, and I'm assuming that these proposals have gone through the primary care management groups locally, but I think they probably also need to go through the kind of borough committee mechanism, or for Wandsworth and Merton, it's something like the KIC, so that people are just cited on it. So I just think there's something about preparing for the future world at the same time as kind of like making sure that everyone's signed up to it. But I agree with the paper. Okay,
John.
Thank you, Sue. I actually wanted to just connect with that point that Mark's just made, and perhaps Katie could give us specifically on diabetes, Katie, where that is in the pecking order for review. I'm asking because Healthwatch Kingston recently published a report about diabetes care, which was really well received by the NHS people that they have to consult. And the point was made that it was well recognised by clinicians that there is considerable variation between practices in Kingston. And it raised a couple of questions for Dr. Hull, particularly about what variation existed in other boroughs. And we think probably in Richmond there is a similar level of variation. But whether how rolling forward or extending the current contract arrangements would play into the need to review these services, and whether the new contract arrangements would provide an early opportunity to look at diabetes and get to the bottom of some of those variations and how it's going to be tackled. Now, obviously, Mark's answered some of that because it will eventually have to reach place. Dr. Hull and others have recognised the role of the QoF in moving things on. So I guess it's about what's the problem across the SWL area. When will diabetes maybe come up for review as an LCS, and how will the local areas be able to play into changing things earlier on?
I might initially give my thoughts, but I can see Andy's hand went up, so I'm sure other colleagues want to comment. But just from my perspective, so in terms of the desktop review that was done initially of all the services, diabetes has come out as very complex in terms of, if you were asking the question of do you want to standardise for South West London, that's an extremely complex thing to do. I'm also not sure boroughs would agree it would be the right thing to do. So I suppose it was categorised as a complex thing to try and tackle as through the LCS review for South West London. However, I know that there's a huge amount of work going on anyway in the boroughs around diabetes, and I'm sure it's in many of the local plans in terms of transformation. And I know from my old role that we had a transformation scheme in Merton and Wandsworth, for example, and I'm sure that's the case in other boroughs as well. So I think that sort of whether it's top of the list for the South West London review versus the sort of work that is already going on in the boroughs is sort of, yeah, I think it's probably something that I'm sure is part of local transformation plans, but I'll let others comment.
Andrew?
Yeah, what I will do, John, is Amit's not here right now, but I'll take away the action to talk to him and then make sure he's connecting in with you as well. And just sort of coming back on Mark's comments and your comments about governance. So LCS at the minute are the local places for determination. What we're trying to do is sort of get a collective meeting of the minds of the brain trust really across South West London with the clinicians to work out best practice. So for SMI, which is our current priority, we're hoping to bring a paper and a proposal to this June meeting for approval, and beforehand it will need to have gone through local place committees, as Mark said, and also local LMCs as well. So hopefully for June time we'll have a new SMI spec that I think everyone feels able to sign up to because of the level of engagement and support it's got from local clinicians and across South West London as well.
Thank you. Mark, did you want to add to that?
I suppose just to say that this piece of work doesn't stop local pieces of work and local prioritised settings and reviews, etc., etc. So it's not that the rest of South West London has to wait for this piece of work to get to diabetes. Local places can be prioritising, changing their specifications, etc., etc. So they should come together as a coherent piece in due course, but places can still prioritise.
Okay, thank you very much. Well, so you really want us just to approve the rollover of the contracts for another year. We are happy to support that proposal. Thank you very much. So the premium services, is that the same issue? Do you want us to?
Yeah, it's a similar vein really, but just to note, so it's here for noting because we have already done a chair's action prior to the meeting around the premium, just because we needed to get the notification out to practices. It's in a similar theme. Obviously, it's a raft of services that support practices to provide additional input to patients. There are some examples in the paper. They are funded per weighted patient, and we previously, this time last year, we had written to practices with a contract variation to say we had an extension of a sort of rollover of the premium services for 1 year with an potential to extend for a further year. So we're at the end of year one of the 1+1 arrangement, and the paper was to confirm that we are enacting the extension for the further year, taking us to March 23. Similar to the previous discussion, obviously we acknowledge there is a need to review. As I said, we've got 160 services across premium and LCS, hugely complex exercise. We have put in the paper a timetable, a draft timetable for looking at some review of the premium KPIs and specifications. But I think it's to note that really, again, as per the last conversation, we would have to prioritise and look at where we know that some of the KPIs have become redundant or less relevant now than they were when they were first drafted. And I think we were looking to work obviously with the borough teams to consider the highest priority areas and what we can reasonably review in the time available. Acknowledging that some of them, there's a lot of work there to do, and we just need to come up with a timetable for how it can be achieved. But we've put in that we'll look to prioritise and take a handful that we're able to deal with next year.
Thank you. Any questions from anybody? Nicola?
Yeah, so I agree with the principle. I don't think there's any other realistic option, to be honest with this. I agree. Just wondering about monitoring of the performance against the PMS KPIs in the current year, because I only know in detail how it works in Wandsworth, but we've got mechanisms for monitoring performance against them, and I guess other areas, other boroughs will have that as well. Those mechanisms won't have been refreshed for a while, I think. probably not in the last year, that's for sure. And so is there an intention to monitor this year so you understand what activity is going on, or do you think that that's probably energies are best focused on the next version, if you see what I mean?
So I think where we are with it is that we are going to be doing some light touch monitoring at the end of this financial year, but only for those areas that are applicable, that, as I said, some of it I think has slightly fallen out of use or may not be so relevant or a good use of anyone's time to collect a lot of data about. I think what we've indicated in the letter that we sent out to practices is a pragmatic approach. So we will do some monitoring, but we're not going to ask practices to spend time collating things that we're not going to find useful, I suppose. So it's sort of trying to get, it's obviously, as you can see in the paper, it's a significant amount of spend. It's nearly £23 million for South West London. So it's trying to get a balance, I think, of we will do some monitoring, probably 3 to 6 monthly, but I don't think we'll go overboard, and we won't ask for things that are no longer relevant.
Thank you. Okay, so we'll note that extension of the contract and plan for 2023. So Paul, I think you're going to pick up the next item, are you?
Yes. Hi, good morning, everyone. So hopefully you've all got a copy of the paper. So we're asking the committee to approve the contract extension and annual uplift payments for the RHN enhanced service, which is awarded to the Wandsworth Medical Centre in 2018. The current extension ends on the 31st of March 2022, so the extension would cover a further year. Wandsworth Primary Care Management Group agreed the extension at their meeting in February. So as you'll see in the paper, we provided some further background on this with details of the service delivery provided by both the RHN and the Wandsworth Medical Centre. Following the pandemic, the contract review meetings have also been resumed by the Wandsworth Borough team. As noted in the paper, there have been 3 extensions so far. However, it's been identified that the service does require comprehensive review to determine the most appropriate future service model, but this has not commenced due to capacity constraints caused by the pandemic. So the service will be reviewed again in 2022-23. The key issue at the moment, so with the timing, we've got with the current extension ending on the 31st of March. If a further extension for a year is not approved, it's lead to a procurement process to identify a new provider, which could cause some impact there with patients in the short term until a new provider is agreed. Details are provided on the annual uplift in the financial section on page 3. The contract allows for a possible annual uplift, and the finance team have reviewed this and proposed an uplift proxy figure of 3.5%, which would increase the annual payments to 142,706 per annum. So that would be paid in monthly instalments. The proxy figure we're looking at would look to align with the confirmed national global sum uplift when this is finalised. Therefore, the above figure will be indicative and will be confirmed as soon as possible, but it's not expected to go above 3.5%. Also, just to note that the RHN usually contributes about £60,000 per year to this as well. So as part of the governance process and due to the financial awards to the practice for delivering the RHN enhanced service, this paper has been provided to the committee to approve the extension and the proposed annual payment uplift.
Thank you. David, did you want to pick up on anything on this?
Paul, can I just ask in terms of is this review happening now? Because if you need to give yourself time, don't you, to complete the review? Because if you then need to go through a procurement, that would take time, and the danger is you would just run out of time, and then you'll have to extend the contract for next year. So I think it's just being clear of what the dates are that you're working to on this.
And Casey, do you want to jump in?
Helpful if I chip in. So in all honesty with you, David, that this review has been many years in the making, not just the last 3 years. and again, Nicola might be able to comment more than I, but my understanding is these are a really vulnerable group of patients, and the feeling from the RHND consultant specialists is that a GP-led model isn't necessarily the right one to have in place. And so over this period of years, we've been working with the Trust on what an integrated care model might look like to look after these patients. And that's the bit of work that I suppose has taken a lot of time to get off the ground because of some of the ins and outs of working across multiple different providers. And that's the bit of work that we now do need to get off the ground again. So in all honesty, it's not happening at the moment. It has very much gone on the back burner, and we will need to start those conversations almost afresh, I think, given the number of changes that have happened both within our team, within the consultant teams and within the commissioning teams that were previously working on it as well.
So again, just to come back, yeah, thanks for that, Kate. Again, it's back to how high a priority is this given everything else. I mean, that's the judgment, you know, that you're going to have to make, because compared to some of the other services that we've in the previous paper where we've signed off big amounts of money, this is in that context a smaller amount of money. So I would just urge you've just got to think through how do you prioritise this given everything else that's going on.
Okay, thank you, David. Julius, welcome to the meeting.
Yeah, so I apologise I'm late. I gave my apologies.
You did, yes.
I was just going to say that the global sum uplift for 2022-23 is already known. It's 2.5%. So that doesn't need to be a sort of speculation. That is what the global sum uplift is for the next financial year, because it's part of the multi-year deal.
Okay, thank you. Andrew?
Yeah, this is probably all my fault, actually, from about 4.5–5 years ago in Wandsworth. And Katie Bugler, actually, who's smiling back at me. So we, I think this used to belong to a practice in another borough at the time, and I think that GP retired. And we had a lot of conversations with the medical directorate at RHND just around these vulnerable the residents, effectively, because they're not going to be discharged back home or back into the community, and obviously they then need some kind of general practice access, and also what that then means in terms of other services that GPs can typically access in a way that RHND as a registered charity can't do. So we did do quite a lot of work for 6 or so months, and the prescribing was quite a big part of it, just on what do we think we needed for these patients for perhaps a couple of year period whilst we could work out the longer term model relevant to specialised commissioning, David, with all the changes that are still happening around specialised. And obviously I think with COVID, this is one that's been in place for quite some time now. So I think it sounds like, and Kate is quite right to say that it's an opportunity throughout the year to look at what is the right model of care for these patients moving forward, because when we did it, we were very mindful that this was a service gap we needed to try and fill for a period of time, but it does sound, and probably quite right, that there's a proper step back and look at the actual model going forwards and whether it is a model like this or actually it is a very different model in place. So I think that's the piece of work that needs to happen over the next 6 months to be leading into this time next year and beyond as well.
So can I just clarify, based on David's point and also the response about quite a complex review and something that's might need to be prioritised against lots of other demands on your time, are we likely to see a rollover for the following year as well? I think we just need to anticipate that, really, and not assume that it's all going to be resolved. Or are you confident that you can complete this so that the model of care will be clear from the following year? Nobody wishes to answer that.
My personal view, based on the capacity of my team at the moment, is that there's likely to be a further rollover.
So I think we just might need to want to note that so that it's clear moving forward, really. So are we happy to approve the rollover on the assumption that this might continue for some time based on the need for a new model, which take longer to deliver than perhaps 1 year? Okay, well done. Thank you very much. And then the Extended Access Hub Croydon contract update. Is that Emily or is that Paul as well?
It's me.
Hello, Emily.
Hi. So the purpose of this paper is to brief Primary Care Commissioning Committee on the 2 contract changes relating to the South West London Extended Access Service, which were approved by Finance Committee on the 25th of January. NHS England had indicated that the extended access service would be transferred to primary care networks on the 1st of April 22. However, on the 14th of October, it was confirmed that the planned transfer of current CCG commissioned extended access services to PCNs would be postponed until October 22. Due to this announcement, the following two contract changes were required. The first was that the CCG were required to recommission the current extended access service provision across all 6 boroughs for an additional 6 months from the 1st of April. The current provision can only be delivered by a provider who has access to each practice's clinical system and an integrated pathway with data sharing incorporated. Therefore, a single tender waiver was approved by Finance Committee to extend the South West London Extended Access Hub for all boroughs for additional 6 months from the 1st of April to the 30th of September. This will enable the CCG to work in collaboration with PCNs and the local systems to ensure a smooth transition of the service by October 22. The second change related to Croydon only. In Croydon, the 5 extended access hubs are currently provided by 2 providers. Croydon GP Collaborative provides the service at 2 hubs, and Primary Care Partners Limited, previously known as AT Medics, provides the service across 3 hubs. Primary Care Partners had informed the CCG that they no longer wish to deliver the service from April onwards, and the current contract would expire on the 31st of March. Therefore, a single tender waiver was approved by Finance Committee to transfer Croydon's full extended access service to Croydon GP Collaborative from the 1st of April 22. This contract is block, and overall contract value will be increased by 190k for 6 months. The funding for this service is provided by NHS England, and the underspend from the primary care at scale budget for Croydon will be used to increase the contract value to reflect the additional resource requirements and delivery costs. Are there any questions?
Thank you. Just to clarify, so for the Croydon bit, because in the last page 3 of 4 of the cover paper that you've done, it says the cost will increase by 129,000. That should be 190. Is that right?
Sorry.
No, it's all right. Good. It's just I'm just getting a bit muddled about what the figures are. Okay.
No, sorry, that's a typo. Yeah, it should be.
And the 190, the increase in cost for Croydon, that's due to the takeover of infrastructure, is it? Or
yeah, I'll let Aisha just advise on that.
Yeah. Okay. First, thank you, Aisha.
Yeah. So the increase in costs reflects that the model previously was delivered by AT Medics, who also run our out of hours hubs. So some of the funding, they use the economies of scale, and it was kind of subsidised. When we looked at the value for money impact on for the additional 190k, it's still good value for money when you compare it to other extended access providers, and we're also getting them to deliver diagnostics and referrals going forward, so it fits more with the PCN delivery model from the 1st of October.
Thank you. David, obviously it's been through finance. Are there any observations you want to share with us? No, fine. Are we then happy to note the 6-month extension, and then presumably at that point then the transfer takes place to the PCNs. Will we need to see anything in June, or that will go to the new contracting arrangements to be noted, will it, Andrew?
Yes, obviously unless there are any changes at national level. So we do have about to kick off various work streams in the background with each of the boroughs, just to make sure that we're working backwards from October the 1st for the new requirements, which are obviously providing top-up cover in the week and then Saturday 9 till 5, very much as an extension of sort of core general practice, but on a PCN type footprint. But I think just to say for now, we are waiting for the technical guidance to follow very soon from NHS England. So once we have that, various groups will start and try and make sure that we've got everything in place for October the 1st. So in theory, we know there shouldn't be any more extensions.
Okay, great, thank you. Right, should we move on then? Borough reports. Thank you very much for all the reports. Really useful to see the notes of the summary of your discussions. One of the things we picked up in the finance report was the Winter Access Fund and how that's been used. It would be useful in your report, but you could also give us a flavour of how that's been able to have an impact locally. And we're also quite interested in how you're adjusting to the vaccination programme and the issues you're having to focus in on. I'm sorry if you haven't had forewarning on that, but I'm sure it's probably bread and butter to the work that you've been doing, but that would be really helpful just to pick up those themes. But I'm happy to be guided by you if there's any other issues that you want us to be noting. So if we go through Merton and Wandsworth, would that be all right, Katie?
Hello, everybody. Actually, so the vaccine work hasn't been my bread and butter because I've only just come back from maternity leave. So
well, welcome back.
It's been many people's bread and butter for gosh, the last 15 months or so, pretty much since I left. But I feel like I feel speaking on behalf of them is when so much has gone on is slightly tricky. But at the moment, the vaccine work is very much focusing on how we basically have a sustainable model going forward. And we've also been doing huge amounts of work on kind of the community outreach side of things. So we've got lots of pop-up clinics that are running across both Merton and Wandsworth at the moment. And we've had some real innovative PCNs that have actually got GPs going out into places like homeless centres and sexual health clinics and talking to people about vaccination in those situations as well, where we know that there's been gaps in the coverage. Our GP colleagues have absolutely stepped up to the plate on this. You know, throughout the COVID pandemic, they've been asked to do this repeatedly, and the vaccine programme, I think, has really strengthened relationships that my team have with the PCN directors as well, simply because they've all had to work together to pull things together so very quickly. And I think the numbers reflect that it's been a huge success. So we have been talking about the vaccine programme in Pcmg in both of our boroughs for quite a long time now, but for the first time, as you can see from the reports, we've started to talk more about the business as usual work again as well. So particularly, we've had a Cqc report in Merton that wasn't quite where we'd have wanted it to be. There's some long-standing issues in the practice that was inspected, and so we are picking up with our practice support team around how we can sort that out. Likewise, in Wandsworth, we've had 2 positive Cqc inspections and 1 that didn't go so well. So again, we're really reinstigating a lot of the work we used to do, you know, as our business as usual stuff around supporting practices in the aftermath of these reports, and also making sure that we share learning from the ones that have gone well. In terms of winter access funds, so I think similar to other boroughs, our focus has been both at a borough level in terms of delivering additional appointments to our access hubs in both Wandsworth and Merton, and also at a practice level as well. And in terms of, I suppose, what the outcomes of that has been, so it's really easy to tell you numbers of appointments. However, I sent an email around to our practice managers asking them how they thought it had impacted them, and I actually had an absolute flood of really positive responses. So just to give you a couple of them. So I think it's been hugely beneficial. It's provided us with the ability to have set regular locums on every day, which has not only increased patient satisfaction and numbers of appointments, but eased pressures on current GPs. And then another one, it's provided resilience. We've had 2 GPs working from home with COVID this week alone, and without those locum sessions, we would have been severely short on face-to-face appointments. Another one, getting locums at short notice has always been really hard, so knowing our budget up front allowed for careful planning for the whole month period, which was fantastic and really made a difference. So I think, whilst that's anecdotal, the raft of responses I had back to the question really does show that it's made a hugely positive difference both to the pressures on practices and I think to the patients that have actually accessed those additional appointments as well. Stop there.
Okay, thank you very much. Shall we go through each of the boroughs and then we'll pick up any questions? There are probably some common themes that are arising, aren't they? Should we move to Croydon then? Aisha, would you want to?
Yeah, thank you. So in terms of the winter access fund, I'll just mirror what Katie said in terms of the practice response being really positive. They have used a lot of the additional capacity to manage patients with long-term conditions, and a lot of the additional roles have also been utilised to support with additional capacity. So that's really helped them during the winter period. The other bit of the WAF funding for us was used on extended access out of hours and the urgent daytime hubs. And that's really helped with capacity across the Croydon system, together with the telephony service as well. So it's meant that we've had lots of additional capacity in the system, and which has been utilised quite effectively. So quite positive overall on the WAF programme. In terms of the Pcmg updates, I think we've already talked about extended access and the issues that we're facing there. There are a number of estates issues because we have capital funding of 10 million in Croydon, and we're working through a number of projects, so that gets discussed quite regularly. In terms of CQC, we had 9 practices that were requires improvement, and that's now changed to 5 practices. So there is some improvement in terms of the quality of practices in Croydon, which I think is positive because we've had quite a number of visits in the last year. It's been quite a difficult time. Yes, I think that provides a summary of where we're at in Croydon.
Thank you very much. Great. Tanya, I think you're going to speak for Richmond and Kingston, is that right?
Yeah,
Welcome.
perfect, thank you. So if I start with the Winter Access Fund, so in Kingston and Richmond, 45 of the 46 practices signed up to deliver the borough level scheme. So that was to increase capacity in primary care, additional GP, nurse and HCA appointments. So there were over 4,000 appointments, additional appointments that were put in using a combination of kind of existing and locum staff. But then in addition to this, practices also put in individual plans. So they were offering substantial further clinical capacity over and above that. So in terms of benefits, practices have reported that they have managed to improve access to appointments. So that includes face-to-face and same-day appointments. This has led to improvements in staff morale, both in the clinical and in the non-clinical workforce. They've seen improvements in patient experience due to shorter waiting times, some reduced pressure on out of hours and emergency services, and also they kind of allowed for some capacity to address the backlog in the admin work as well that had been kind of building up over the last year or so. Similar to the other boroughs, we've also managed to increase capacity in the local GP access hubs. So this has kind of supported the wider system by providing NHS 111 with some more bookable appointments in primary care. And although we're kind of waiting to see how many of these appointments have been booked and filled, there are around 300 additional appointments in December, I think. So generally, it's all been very positive feedback from the WAF scheme, and we've been able to really support better access in primary care through the use of that funding. In terms of the vaccine work, I think similar to the other boroughs as well, that we're currently focusing on the Spring Booster programme and how we could best kind of continue to deliver the programme alongside the business as usual commitments that are coming in. I think the South West London vaccination figures really do reflect the hard work that GP practices have put into this over the last 15 months. The LVSs have been, the local vaccination sites have really been pivotal to delivering this vaccination programme in the local boroughs. So I think at the moment we're kind of at a juncture where we're just looking at how we can develop this programme to continue over and to deliver the ask over the next year, which has changed slightly from what it was last year. And then finally, just to talk about the Pcmg report. So we talked about the current contractual position with regards to the LCSs and the premium services. So what Katie and Paul touched on earlier in this meeting, and our intention to hopefully roll those over into next year. In terms of CQC, we did review a recent CQC report relating to one of our surgeries in Kingston. They were rated as requires improvement overall. So we talked about the issue of a remedial notice and how we're working with that practice and the CQC to address the contractual issues that have been noted there. And we also, as per usual, talked about our primary care quality report. And for this month, we did a deep dive into cancer screening and prevention across Kingston and Richmond and looked at the data across the practices in relation to that. I think they're the key points. Thanks.
Great, thank you. Now we're going to come to Sutton. I've got Sian down, but is it Lou that's? Oh, it is Sian. All right. Okay. Great. Couldn't see you on my list of participants. That's all.
Oh, no, I am here. Yes. So in Sutton, the majority of our winter access funding, the practices decided to pool and deliver sort of borough-wide services with it to alleviate pressure from individual practices. A lot of additional capacity has been put into extended access hubs. That we've opened 2 more extended access hubs, so we now have 4 in the borough, so 1 in each of the primary care networks. Previously we only had 2. That's basically doubled our extended access capacity. The primary care network team have also been running a service every weekend to answer phone calls, and not just answer phone calls and sort of only deal with very urgent things on the day, but actually they're dealing with routine things as well. They're finding that patients are phoning them with queries about test results, or about their referrals, or about their NHS app COVID status. So all sorts of things that actually, although not necessarily urgent at the weekend, those calls would come into practices on a Monday, and practices have reported that they've really noticed that Mondays or post-bank holidays are not as busy as they would have expected them to be through the winter period while we've been running that scheme. It's been really appreciated by the practices. We've also been running a paediatric clinic, so from 4 till 8 every weekday. That's providing just over 100 appointments every week, and again that is well utilised, dealing with providing that extra capacity for when children are coming home from school or being picked up from nursery and not feeling well. And again, that's alleviating pressure in practices to try to see children towards the end of their working day, that actually they can be seen in that hub instead. A wound care clinic has been set up. So again, this is a borough-wide service that wound care can take up an awful lot of nursing time within practices, and having that additional resource again is freeing up practice nurse time in practices for other work with that complex wound care being done in a hub. And I did want to just try and, let's see if the technology works. I'm just going to try and project to you my screen, if you can see it. And this is just a chart that we looked at. So this is looking at emergency department walk-in activity at St Helier between 8 a.m. and 8 p.m. on weekdays through the, so looking at what was happening in October through to the end of January. And what you can see is a real step change, and that step change was on the 18th of December, which just happened to be when the PCN team started their weekend switchboard, and also the additional capacity within the extended access hubs. We need to sort of follow that through. You can sort of see it's looked to be going up a little bit towards the very end of January, and we will sort of continue to follow that. But you can really see that for those patients arriving at St Helier not by ambulance, there's absolutely been a very noticeable change when that capacity kicked in.
Interesting, thank you.
And then, sorry, COVID vaccinations. So yes, our PCNs have continued to do that. Going forward, they are looking to concentrate on the care home and housebound and hard to reach groups. And we'll be working with the mass vaccination team around the sort of more ambulatory people getting their boosters. So I'll take that down. Thank you.
Thank you very much, Sian. Very helpful. Nicola, did you want to make some comments about the vaccination programme?
Yeah, if I may, thank you, because I'm sort of really keen that I was glad you asked for particular comments about it, Susan, because I think it's really important that we do continue to recognise what a huge programme this is still, and that practices and PCNs are still doing an enormous amount of work, and it's sort of less visible now, really. But I think it's even more challenging in the face of not just the business as usual to the extent that anything is usual, but really a whole raft of new initiatives and approaches and things that are being asked of practices in the coming year. And yet they're still, standing up and saying, yes, we'll continue with, huge chunks of this vaccination programme. And pretty much every month there's a new thing, a new cohort, or, a new approach that we need to use, or, new operating procedures or whatever. And so, it's extraordinary, really, the amount of willingness and flexibility. And just illustrative of what's going on. So on the 21st of March, the programme for the spring booster starts for RO75s and immunocompromised, and many sites still don't know which type of vaccine they'll be using, because Moderna is going to be used. And just that means that whole team has to be trained in a way that they've never done this vaccine before. People are willing to do this. It's just quite extraordinary. And I wanted to put on record, really, my thanks for what's gone before for all practices and PCNs, and in fact the South West London CCG team, the primary care team, has been amazing. I can't tell you how much this has been appreciated by practices, the support that they've had from the team. So thanks, guys, as well.
Thank you. I mean, my observation was also a bit about the Winter Access Fund and the positive feedback that you've been getting and the impact it's had. And I recognise that there is additional money to go in the system to support that, but it's whether there's any learning in terms of a new way of delivering primary care that relieves the burdens that people are seeing, or is it just because winter doesn't seem to go away? Winter seems to be throughout the year, or it has been for some time, hasn't it? But it'd be interesting to know whether there's anything people are taking away from that. Perhaps not for today, but perhaps next time, just to think about. It seemed to have such a positive way forward, didn't it? But recognising that obviously it came with new resources that perhaps we don't have on a sustainable basis. But yes, Bruno, did you want to comment on something?
I just wanted to thank everybody for the kind of further information they've been able to give about the vaccination program, because it's become all the more important because of the wind down in testing. So we'll be less cited on precisely what's happening, and also on the kind of non-pharmaceutical interventions such as wearing masks and social distancing and things like that. So it's going to be a critical element of the way in which health responds to it going forward.
Thank you. Mark.
Well, mine's just going back to the access. So we know that many practices have, there's been kind of lots of negative perceptions about gaining access into primary care, and I just wonder, in terms of some of the great work that's been done, but also access going forward, we're working with our comms colleagues to kind of make sure that South West London, that we are actually promoting access, making sure that people know how to access and where to access, because I think that's it's really key, and it would also support our primary care clinicians as well, because I know that many of them are getting quite angry, angry patients phoning them, etc. There's something, I think, from a comms perspective we need to do around access.
Okay, thank you. Presumably not wanting a comment now, particularly Mark, just logging that as an issue to take forward. Is that right? Okay. Thank you very much, everybody. Well done, everybody, for all the work that's going on in primary care. We'll now move on to the Cqc Remedial Notices. Katie, I think you're going to cover a couple of them, and then Paul, is that right?
So yeah, Kathy's going to go for the first two. And
then,
Kathy,
right,
yeah,
sorry. Yeah. Kathy's and Katie's, I apologise.
Quite a few of us, aren't there? Thank you. So for Croydon, we've had two remedial notices that we've agreed through Pcmg, one for East Croydon Medical Centre and one for Edridge Road are for the committee with a summary of the concerns identified in the Cqc's reports published in December. And we're asking for the Cqc, for the committee to ratify the Pcmg's decision at their meeting in January to issue the practice with a remedial notice. The notice for East Croydon Medical Centre was issued in February, and that the practice have actually responded since then, so their response will be reviewed. So basically, the report rated East Croydon Medical Centre as requiring improvement overall, which was the same overall rating as per the previous two inspections, one in 2019 and one in 2018. And before I go any further, just to say that, as noted on this paper, East Croydon
Have I lost it, or has Kathy lost it? I think you're.
I think it's Kathy that we've lost.
Oh, good. Oh, good. You never quite tell if it's yourself or the recipient. Does anybody want to?
Kathy, you may want to switch your camera off. I think it might be your Wi-Fi, Kathy. Oh, she's gone. I think probably when I'm sure she'll rejoin. I think probably what Kathy was about to say was around the I imagine what she was about to say was around it's the same partners on the two contracts, East Croydon and Edridge Road. Hi Kathy, you're back. I think we lost you. It might be your camera. And so there have been the inspections have been sort of together, but they're two separate contracts. So they're two papers because they're separate contracts, but they're sort of some of the issues overlap. They're not exactly the same, but there is overlap. Kathy, I was just guessing what you might have been about to say.
Yes, thank you. Sorry about that. Isn't that typical? Isn't that typical? So yes, so we have reported on these practices jointly before because that's what the CQC did, but now they've separated out the registration so that it's clearer for us in terms of reporting to you as well. So East Croydon Medical Centre came out with 3 areas requiring improvement, which means not much change has happened apart from they are good for responsive, which they weren't last time round, and there's no change for the caring domain, which is still good. So after the first visit in 2018, the Pcmg at the time decided not to issue a remedial notice, but for the CCG to support the practice to improve. And then the next year, after the November inspection, it was decided to issue a remedial notice and for support to be given to the practice to improve. And then in March 2021, because of the change in the way we were working with COVID, it was agreed to lift the remedial notice, which was an agreement across the board where practices had submitted action plans that were deemed to be satisfactory, then those remedial notices could be lifted. So that's what happened in this case. So the latest issues specifically are around providing safe services and effective services. And I've listed the reasons given. So to take a couple of examples, systems around management of medicines had not been sufficiently improved, and expired equipment in the practice's emergency supply stores were found. In terms of effective services, the uptake of childhood IMS and cervical screening were below average. They hadn't improved. And another example would be incorrect coding of medication reviews created a risk that patients prescribed multiple medicines might not have all the medication reviewed in line with guidance.
Kathy, can I just ask, so did you just say that they're the same GPs that run both practices?
Same contractors. Yes.
Same contractors.
Yes.
But they have separate contracts for each of those
Yes.
units. So the likelihood is that if they're not good at leading in one, they're not going to be good at leading in the other, and that the action plans are going to have some similarities, are they? And I just wondered, presumably there is a clear plan that reaches, you look at them across the two sites really, because even though they are separate contracts, surely the same issues need to be addressed, and you're getting a similar response, are you, in terms of an action plan?
Getting a similar response, but in terms of Edridge Road, they've actually they only have 2 areas of requiring improvement, whereas East Croydon Medical Centre has 3. So, but well led is appropriate to both. They both fall down on being well led. But I think the difference is its effectiveness. It's Edridge Road do better on effective the effective domain.
Interesting, they can't learn from each other then. But I mean, so what you're asking for us is to ratify the approval for the remedial notice. Just give us confidence that there's a clear risk register for each and action plans being produced. Is that right?
Correct. Yeah, I have heard back from the contractors, so that needs, their response needs to be reviewed.
So it isn't necessarily the same practitioners, but it's the same overall organisation that manages the two sites, right? Okay, fine. Sorry to stop you. I mean, very comprehensive reports. That was really helpful to see that. Has anybody got any other questions that they want to ask, Kathy? No, I think that's a really helpful way you set it out, very clear, and I think we're happy to ratify the approval. Thank you very much.
Thank you. So is that for both of them? So I don't.
That's for both of them, yeah. You set it out well in terms of all the issues. So thank you very much.
Thank you. Thanks a lot.
Paul, do you want to just highlight any issues for us around Trinity Medical Centre?
Yes, so the Trinity Medical Centre, the practice was recently rated overall inadequate by the CQC. So the committee are asked to ratify Wandsworth Primary Care Management Group's decision to issue a remedial notice to the practice following the recent CQC inspection. The practice had also been placed under special measures by the CQC as well. So the South West London Standard Operating Procedure does recommend that any practice that's rated overall inadequate is issued a remedial notice. So as you've seen in the paper, we provided some background to the practice and with some details of the contractual clauses and regulations that they are in breach of. A summary of the key issues are also provided in the paper. So these include themes such as staff training, leadership capability and capacity, and clinical audit and review. We had an initial meeting with the practice on the 22nd of February, and they did provide some assurance that they've begun to address the issues identified and welcome the support offered by the Borough team, who will establish a task and finish group to provide the necessary support to the practice to help them to improve. The remedial notice has just recently been issued to the practice, initially giving them 28 days to complete an action plan. However, we received an update from the practice yesterday that due to some staffing, staff sickness and absence, just requesting a bit of an extension to the action plan. We discussed this with the Wandsworth Primary Care Management Group just before this meeting, and that's been and the group were happy with to provide an extension if needed. So today the committee are just asked to ratify the group's decision in issuing this remedial notice to the practice.
Can I just check then, because if they're inadequate as a practice, then that's presumably much higher risk for us, for our patients, than the other areas. Presumably there is more regular contact and rigour in the monitoring of improvement within this practice. And are we likely to see anything back at our next meeting in terms of progress?
Yes, we can provide an update at the next meeting. Yes.
Kathy.
Sorry, Katie, but
Katie.
so yeah, I just wanted to really reiterate that so we had our primary care management group just before this meeting and talked about this request for an extension, which concerned us a bit, and we have said that actually we will need to have more regular touch points with the practice. We're going to support we felt we would support the extension because they do have a number of GPs off with COVID at the moment, and so obviously capacity to respond to an action plan and maintain safe services. We obviously want them to focus on the safe services, but we will both our local task and finish group, which it will have a clinical lead around the table, will be getting 2 weekly meetings in the diary with them, so that we make sure that actually we're keeping on top of the quality of care that's being delivered by the practice.
Any questions, David, Mark? No, okay. Thank you very much. Okay, so we're just being asked to ratify the remedial notice. We're happy to do so. Thank you. Mark, do you want to say something?
And I suppose it's just around kind of and I don't think it's for this meeting. It's probably for us to discuss offline, just around how that's monitored and how it gets reported, and then what comes back to this committee. But also going back to the East Croydon and there does seem to be a kind of cycle there, doesn't there? There's a cycle of requires improvement, action plan, requires improvement, action plan, and so I suppose what's the ultimate outcome is something that I need to, I've been I'd like to talk to the team about, and people like Julius and Nicola, etc., is about when do you stop, when do you get off that continuous cycle, so to speak. So I think that's something that I just, it kind of came up for me.
Thank you. Yes, helpful point. Okay, right, to move on then to the Grove Road list closures. Sian, are you leading on this?
It's got my note, but Paul's going to present it as his paper.
Okay.
Okay. Yes, so the committee are asked to ratify Sutton Primary Care Management's decision in agreeing the practice's request to close their list for a period of 12 months. During this time, that would mean that new patients would not be able to register with the practice. However, the following groups remain unaffected by this. That's newborns of registered patients and care homes and learning disability homes within their catchment area. The reason for the practice's request is due to severe capacity constraints following a steady rise in list size over the years. The practice has identified a short-term solution in improving their capacity and in order to also take on some more staff by reconfiguring the interior premises and constructing a demountable office space in the garden. This work would take about 12 months to complete, so this request would be seen as sort of easing some of the pressure on the practice while they make the necessary improvements to their premises. They are looking for a long-term solution as well by trying to identify new premises to move into, but this option could take quite a few years and obviously would need to be approved. So the paper provides just some further information, details of the practice. So as noted, there are 4 clinical partners holding a PMS contract. Currently, there are 5 clinical rooms and 2 treatment rooms, but based on list size guidance, 7 clinical rooms would be recommended. A list of local practices within 1 mile of Grove Road have been provided. Just to note that 2 of these have received recent investment, which allow capacity to take on new patients. The list size figures have been provided, and that shows an increase of about 1,300 patients since January 2018. Provided a bit more detail on their premises constraints, capacity issues, some feedback from their PPG and local practices. No concerns have been noted. Some further details there on the short-term and longer-term solutions that they've been looking into. And just to note, they are a well-performing practice and do have good positive feedback on the NHS website. So as noted in the paper, the Sutton Primary Care Management Group met on the 1st of March and they agreed with option 1 in the paper to close the list for 12 months, following recognition of the severe capacity constraints at the practice. This includes a caveat that this will be reviewed by the borough team in 6 months' time on both the short and longer term plans to reconfigure and relocate, with noting that there will be no guarantee of an extension. The group has considered the request as exceptional and there are no undue concerns about setting a precedent within the area. If approved, the South West London team and the borough teams will meet and discuss next steps, agree timescales, the communications required to action a request, etc. And an update will be brought to the Sutton Primary Care Management Group in 6 months' time. So, yep, as noted, the committee has just asked to ratify the group's decision today. Thank you.
Thank you. Julius, did you want to comment?
Yes, I do. Unless the regulations have changed, you're not allowed to include that provision for registering certain cohorts within a closed list. The only patients that you can allow to be registered in a closed list are people who are effectively first-degree relatives or living in the same household as an already registered patient. So I would definitely suggest that point is queried, because I don't think you can exclude or include any other cohorts apart from family members in the same residence in your closed list policy.
Did you want to comment on that, Paul?
As it stands, I don't think that's this can't be approved because I don't think that complies with the regulations that govern closure of lists.
Thanks, Julius. This is just based on feedback provided by the practice as part of their application that they wanted to provide assurance that.
I I don't think you're allowed to, so I think you need to check that aspect of the regulations before we approve this. Because I couldn't approve or suggest that the group approves this because it doesn't comply with the regulations as far as I'm aware of them. If they've changed, then obviously that's different. But that was my understanding of closed list regulations. I don't know if Andy has any comment on that.
Andrew?
Andy just vanished.
Right, good.
I think it's dropped off. So
We
yeah,
saw
we
you
need to
coming,
get
Julius.
outside, Susan. Yeah, absolutely. Thank you, Julius.
Do you want to take that outside the meeting then?
Yeah.
And
Yeah.
so does that mean that you, subject to that change, you're looking for us to so I think the principle of doing something to reduce the demands on the practice is a sensible one to go forward with. I was quite interested, with my old hat on of Sutton, to understand how this sits with the wider challenges that Centre Sutton has had around the growth in population. Because do I remember correctly, the extension of Old Courthouse and Robin Hood Lane being a whole discussion about making sure you've got the right capacity. Is this being looked at in that context, Sian?
Yeah, so as Paul noted in the paper, that there is additional capacity available at Robin Hood Lane and at Old Courthouse following recent investment to increase their space, and that is part of our strategy about increasing capacity within the town centre. As you know, patients can choose to register where they like, and patients have chosen to register at Grove Road, which did not have additional capacity to register people. And in particular, Grove Road have registered hundreds of Hong Kong settlers that has also put additional strain on the practice because they've come with specific needs. So really what we're looking to do is to redirect those sort of patients for the next year to the practices that have the space and the workforce to manage a growing list size, whereas Grove Road just doesn't have the space at the moment. This is why we feel it doesn't really set a precedent from the point of view that there are nearby practices with capacity which probably wouldn't be the case if we were talking about a different area within the borough. And they do have a plan about how they can increase space within the practice over the next year. So, but we'll be working closely with them to make sure that those plans happen.
Okay, thank you. Okay, so we're approving, subject to clarification on the regulations. A solution needs to be found to close the list some way, to give them space to find an alternative capacity. Is that right, Paul? Is that what you're asking for us to do?
Yes, please, yeah.
Perhaps you could just send me a briefing afterwards if there's a discussion that we need to, if anything happens that's different to that.
Yeah, sorry, Julius moved, turned off his camera. So I presume the issue is around the registering of new care home residents. It's not the issue around newborns, because they would be family members of existing patients.
Family members, yes. I'm not. I mean, obviously, this is not my area, but Asia's on holiday. It's we don't object to the suggestion of closure at all. It seems very appropriate. But it's the interpretation of the regulations that was given in that description. I think that needs to be checked.
Yeah, no, we'll do that. Yeah.
Thank you very much. Good. I think we've come to the end of the main items. Is there any other business? No? Right. I don't think we've had any public questions, have we, Yvonne? So I shall close the meeting, and thank you very much. For those who are due to be part of the part 2 discussion, can I suggest we convene at 11:30? If you could do that, that would be great. Time for a coffee. And thank you all very much for all your work. Very interesting information that you've shared with us today. See you in June.
Thank you.
Thank you.
Bye.
Thanks, all.
Thank you.
Thanks, everyone.